Good afternoon, and welcome to our ninth session in our first virtual Successful Aging Expo. Today's session is entitled Palliative and Hospice Care. My name is Al Manzi. I'm the president and CEO for Prairie Mountain Media and publisher for the Times Call. Before we start, I'd like to remind everybody about the question and answer and chat functions on the bottom of your screen, and you can use these anytime during the presentation. When you have a question, you can type it in either in chat or in Q&A. And at the end of the session, we'll have what hopefully will be a lively question and answer session after our presentation. So please feel free to do that. Today's presenter is Jessica O'Leary. She's a patient care specialist with TRU Community Care. So please join me in welcoming Jessica O'Leary.
Good afternoon, everyone. Al, can you hear me okay?
I can, you're perfect.
Okay, great. Okay, thanks for joining me for an important topic that far too often we avoid speaking about until much too late. And none of us are getting out of this life alive, so why not learn about something that is inevitably in our future? TRU Community Care, a little bit about us. We are a local not-for-profit. We've been serving this community for over 40 years. We have a couple different support systems in our under our TRU umbrella. We offer hospice, palliative care. We have extensive grief counseling, which we will talk more about during the presentation. And then we also have a PACE program, which Sam Black spoke about as part of Successful Aging earlier this week. So if you haven't seen her presentation, you can certainly view that on Prairie Media's website. So we're going to be addressing palliative care and hospice, and often these two words are considered synonyms, but that is not accurate. They are two separate programs with two different support structures. So we are going to speak to both of them and make sure you understand what's similar about them, what is different about them, and go through some of the misconceptions and myths. Hospice, I think, is one of the most misunderstood support systems in healthcare and is one of the most beautiful aspects of healthcare at one of the most difficult times in yourself or your loved one's life. And often people avoid palliative care and hospice because of those misconceptions. So hopefully we can go through those today. And as Al mentioned, if you have questions, don't hesitate to let us know what those are, and we'll get to those at the end. All right, so let's go through what's similar about them. Serious illness is the focus, is our specialty in both palliative care and hospice. And we provide support for those with serious illness and their loved ones. And we do that with a collaborative interdisciplinary team. We shorten that to an IDT. And we are focusing on not just the person, but their family. And the specialty in palliative care and hospice that is often overlooked in other forms of our healthcare system is that we're not just seeing a cancer patient or a cardiac patient. We are identifying this person as a person living with a serious illness, person with a life-limiting illness, not just a person with cancer, okay? So that's really important, and that's why we're focusing on the entire picture of this individual's life, their physical, their emotional, and their spiritual needs. We provide palliative care and hospice wherever patients call home, okay? So one of the misconceptions is that this is a place you have to go to. Not necessarily. We are going to you wherever you live. The goal of our involvement is to increase your overall quality of life. There are multiple, thousands of organizations that offer palliative care and hospice. Not all hospice organizations have palliative care, but most palliative programs are associated with an organization that provides hospice. So I think one of the fear factors is that when palliative care is introduced, most of the time it's associated with a hospice program, and that creates fear, and then people don't enroll in palliative care because they think it's hospice. I had a patient's husband a few weeks ago asked me if palliative care was hospice in disguise, and that is not what palliative care is. It is an entirely separate program. So that last bullet point on this slide says hospice is palliative care, but palliative care is not hospice. So two separate programs, okay? Keep that in mind. I met with a woman earlier this week in the hospital, and went in and was talking to her about palliative care, and if she could have gotten out of her hospital bed and slammed the door in my face, she would have, because she was so fearful that I was trying to discuss hospice with her. Palliative care. This is more in depth specifically about palliative care. Palliative care does not take the place of any support you already have in place. So we are not taking you away from your current physician or your current specialist. We are in addition. So I want you to see palliative care as a consultative model. I want you to see palliative care as another specialist that you are adding on to your team. As a subspecialty in medicine, we are focusing on symptom burdens that are a result of serious illness, or symptoms that are a result of the treatment of the serious illness, or both. Either way, whatever is causing the symptom burden, it is reducing your overall quality of life. And palliative care, as I mentioned in the previous slide, the goal is to increase your quality of life. What can you expect from a conversation with palliative care is we're going to address your goals of care and versus your goals of treatment. So in other specialties and other forms of your treatment, it's very treatment focused, which is what you would want. You want to get treatment to improve and get better and do whatever you can to fight. But a lot of times in those conversations, what gets lost is your goals of care. And that's where I go back to the point, as we're focusing on the person who has the serious illness, not the serious illness by itself. So what is you as the person or your loved ones? What are your goals of care? Is your goal to be able to get up out of bed independently and go to the bathroom? Is your goal to be able to go for a hike in our beautiful Colorado mountains? What are your individual goals? Is it to spend more time with family so you're not as exhausted or out of breath? What are those goals? What's important to you? And what can we do as a palliative care team to help make that possible? Advanced directives. If you've gone to events in the community, and I'm sure Successful Aging or other events have addressed advanced directives, if this has been something on your to-do list, please take it off the to-do list. In the matter of you're crossing it off because you've completed it, advanced directives are so important, and this is not something you want to wait to do. Advanced directives is one of the best gifts you can provide to your loved ones. TRU Community Care has a beautiful partnership with the Conversation Project. So if this is something you need help with, palliative care, of course, we're going to talk about that, but the Conversation Project, you can go on TRU's website and get access to one of our Conversation Project staff members or volunteers to help you with that. So advanced directives, back to goals of care and goals of treatment. Advanced directives, medical power of attorney, living will, a MOST form, which stands for medical order for scope of treatment, DNRs. Those are all documents that our skilled providers can sit down with you to address and make sure those advanced directives speak to your current wishes, your current needs. Sometimes those of you that have done advanced directives, you've done them decades ago and they're sitting in a safe deposit box, and they really need to be taken out of that box or dusted off and make sure they're current. Palliative team has time, something that is not usual for a provider to have time with their patients, but it is not uncommon for a palliative provider to spend an hour or longer with their patients. If you're in palliative care, there's a serious illness, and the average patient sees their doctor or provider about 8 to 12 minutes. When you have a serious illness and all that's associated with that, 8 to 12 minutes is nearly not enough. So time. And the holistic approach is what I mentioned earlier, is looking at the entire picture of what's going on with you and your loved ones. We are helping with coordination, navigation of resources, serious illness takes a toll on everybody and it takes a village. This is teamwork, and sometimes there are tons of resources out there, but the serious illness is preventing you from being able to even realize what resources are available. So let us help you do that. Big distinguishing factor between palliative care and hospice. So this is one of the biggest takeaways I want you to understand about palliative care, is that palliative care is provided alongside curative treatment. So this includes oncology treatment, hospitalizations, rehabilitation, physical therapy, occupational therapy, anything that with the goal of getting you better, extending your life, going for a cure, interventions. Palliative care can be alongside all of that, okay? There are several different types of palliative care. I'm not going to get into a high level of detail here. This is more information so you're aware that palliative care comes in different forms. So I already mentioned that most palliative care is associated with hospice in the community models. Palliative care can be a medical model, or it can be a home health model. The major difference between those two is home health model is sometimes provided by a home health organization, and you are limited to home health guidelines, which means person has to be homebound, and it's governed under home health regulations. So there's usually involvement for a limited period of time. A medical model is not confined to home health restrictions, meaning you do not have to be homebound, and you are not limited to a specific amount of time, because it is providers, doctors, nurse practitioners making visits, home visits. So you can have palliative care involved as long as you want. Hospital versus community-based models. Some hospitals have an internal palliative team. Some of those teams include medical providers, nurse practitioners, or physicians. Some include social workers or chaplains. So if you are at a hospital, find out if they have a palliative team in-house. And if they do, and that's something you want, you can ask for more information. If the hospital does not have a palliative team in-house, sometimes they have a partnership with a palliative organization, or they can send you get a palliative team involved at your discharge. What to expect from palliative care. When I created this presentation, I spoke to the questions that normally come up in my conversations with patients. So I created and wrote these slides in this presentation as an outline to the conversations I have with people all day, every day, because these are the most common questions. And I typically speak to those and answer questions that you didn't even think you would have. So hopefully that is beneficial to you all today. So who's on the palliative team? This particular, I'm focusing on a medical model when I answer these questions, and that is because TRU has a medical model and we have a home health model through our Kaiser program, our Kaiser affiliation. But I'm speaking to a medical model, and I am trying to speak to a general palliative medical model. And I have to remind you that not all programs are one size fits all. So hopefully this is information you could take with you and guide you if you're ever getting involved with palliative care or hospice. Who's on the team? So physicians and or nurse practitioners, social workers and chaplains. Our physicians and nurse practitioners, they're helping with symptom management, the physical needs. They're reaching out to your healthcare team, your physicians, your specialists, whoever you already have involvement with. They certainly can write prescriptions. They have prescriptive authority, but it's unusual for our providers to write prescriptions. It's not because they can't, it's because our preference is for this to be a collaborative approach to medicine. So if we're off doing our own thing on the sideline, then we're not getting buy-in and understanding of what our role is with your healthcare team. So our preference is to have it be a collaboration. So we would discuss with you and your loved ones what our recommendations would be. And it might not be medications. It might be a different approach. It could be extensive education about your serious illness. Medications are not always associated, but sometimes they are. And then we would discuss with you if you would be open to that, if you've had experience with those medications, and then we would make those recommendations to the primary care physician or the specialist. And then follow up, of course, after those medications were implemented to see the effectiveness. Social workers and chaplains is for that resource navigation and that emotional support, not just for patients, but for loved ones. This is a lot on everybody. So we want to make sure we are taking care of, we're surrounding everybody with support. RNs can be part of a palliative team. TRU certainly has a palliative RN who is making telemedicine, telehealth visits, and doing follow-up phone call support. Our TRU's palliative RN is typically not making house calls. And it takes a village, so we certainly have a number of other staff and volunteers as part of our team. Volunteers are not just directly related to hospice for TRU's program. We have volunteers on our palliative team. How often? This is a big question. How often? One of my providers saw a patient this week who really just can't be bothered with seeing anybody else. And he's like, so do I have to see you? How often do I have to see you? Visit frequency is determined by the patient and their illness. We do not dictate how often we see you, and it's a conversation. On average, palliative patients are seen about once a month by their provider, but it is not uncommon for them to be seen less frequently than that or even more frequently than that. I have palliative patients that are seen once a week, palliative patients that are seen once every few months. So it depends on your illness, how you're doing, and as things change. Where do they make visits? So as I mentioned on the first slide, we're going to your house, wherever you live, if that's at home in the community, if that's a facility, assisted living, a nursing facility, a rehab, if that's in a hospital. And COVID has changed everything, as we all know, and we are certainly doing virtual visits. How long can palliative care be involved for? So serious illness, the ideal time to get palliative care involved is at diagnosis, but it is more common for patients to see a palliative team 1 to 2 years in their last 1 to 2 years of life expectancy. And the average palliative patient with TRU is on service about 4 to 5 months, but it is not uncommon for us to have palliative patients for 2 years or longer. Who pays for this? It is considered the medical model is considered a specialty in medicine. So we bill as specialists. So Medicare, Medicaid, private insurance covers palliative care. There may or may not be copays. So if palliative care was something you were interested in, you would certainly ask those good questions and you would find out if there was any out-of-pocket expense in advance. But Medicare and Medicaid does cover palliative care. When do I add it? Most important question. Diagnosis of life-limiting serious illness at any stage, at any age. So palliative care is not something that only older adults need. We certainly have palliative patients in their 20s and 30s and 40s and so on. So palliative care can be for anybody with a diagnosis of life-limiting serious illness. In a study about palliative care and oncology patients, it was indicated that at diagnosis, palliative care would be beneficial. And then you establish that rapport and that continuity. And as things change in your disease process, palliative care may increase or decrease the visit frequency based on what's going on. If you are somebody or a loved one is having multiple hospitalizations, that would be a time to get palliative care involved. One of the features of palliative care is to reduce the need to go to the hospital. We certainly do not prevent it because you have the right to go to the hospital, as I mentioned, but we can reduce the need to go to the hospital. A lot of hospitalizations are a result of symptoms. And if you have symptoms that are being well managed, we may be able to reduce the need to go to the hospital. If you're transitioning from rehab to home or from the hospital to rehab or to a facility, palliative care would be a good time to get involved then. As I mentioned, it's advanced directives. That's something we can assist with. Sometimes our palliative care providers are called in to meet with a patient or family just to complete advanced directives and then might not need palliative care moving forward. So that's sometimes a reason that we get called in. And our providers can certainly sign advanced directives, the medical advanced directives, the medical order for scope of treatment or DNRs. Assistance with goals of care that match medical treatments. I think we've talked about that extensively. So if there was a specific goal in mind, a time frame, we have patients that come to us with specific life events that they want to be able to reach. for a specific reason, and that's the most important to them. So is there something that we can do to help them make that goal happen? And it can be discontinued and reestablished at any point. So this is not something, it's not a gym membership. You're not signing a contract. You can enroll and kick us to the curb anytime, or we may determine that, you know, you're doing really well and you might not need us at this point, but we're hanging out in the wings if something changes. So let's transition now to a deeper dive into hospice. So those of you that are listening, if you have questions about palliative care, either put them in that chat feature and then we'll get to them at the end, or write them down and we can get to them at the end. But right now we're going to transition to hospice. So hospice, one of the most misunderstood support systems. And that lack of understanding and that fear of this scary word of hospice causes people to not reach out to hospice teams soon enough. So I hope that we can talk through some of those myths today. Hospice is a philosophy of care that focuses on keeping loved ones or yourself comfortable with expert symptom management. Hospice is about living with as much quality of life as possible for however long somebody has left. Hospice is often associated with dying, but I'm asking you to reframe that and understand that hospice is about living for as much time as you have left. I have a dear friend who just lost their mom yesterday in another state, and she was living in nursing homes for the last few months. And in this last month, they were able to take her home and surround her with support because they had hospice support, and they were allowed to have her do exactly what she wanted to do and live, which it was just a beautiful way to support this woman's last final days. So we are supporting patients, families, caregivers, loved ones before the end of life, during the end of life phase, and after. So while a person is in the last few months, weeks, days of life, we're providing that support. During, so there's a specific time period in the end of life situation where we are identified that this person is actively dying, we are increasing our support during that time. And then when a loved one dies, your hospice team continues to be involved providing grief support. Holistic support is involved, just like with palliative care, the physical, the emotional, and the spiritual. Hospice, so this is a big change with palliative care and hospice. So hospice is a support that is available 24 hours a day, 7 days a week, wherever the patient calls home. Hospice replaces 911, okay? So when hospice is involved, you are calling your hospice team. Christmas Day, 3 o'clock in the morning on a blizzard. We are very popular at 3 o'clock in the morning. We replace 911. So we have staff around the clock to meet those needs. If we are replacing 911, we have to be able to meet those needs for people with serious illness. So we are at your beck and call 7 days a week. Our focus is on comfort. We are not involved when people are still pursuing curative interventions. When hospice gets involved, it means that our patients with serious illness have elected, or their doctors have elected, to stop curative life-prolonging interventions. So when we get involved, the conversation has been that this person, family has decided that they want to focus on quality of life and comfort and stop prolonging interventions. There are some exceptions to that. So some things to keep in mind: antibiotics are included in hospice. Hospice certainly will provide antibiotics if the goal is comfort. Typically, we will provide oral antibiotics and we don't do IV antibiotics, but don't not call us because you have something. You want to ask questions, ask questions. On CPR, although we will continue to have conversations on CPR and do not resuscitate. Some people think that hospice, you have to have a do not resuscitate, and that is not accurate. But your philosophy, we want our philosophies to be in sync. So the philosophy overall would be comfort. Not all programs are one size fits all. I can say that for palliative and hospice. So this is where this education you're getting today will help you create questions if you're interviewing hospice organizations. Because I mentioned there are many hospice providers across the country. What to expect? Who's on the team? So misconception is that when you enroll your loved one or yourself in hospice, you give up your primary physician or your specialist. Not necessarily true. You get to keep them. We want to involve them. They have the history with you. They know what's been going on. So you keep your primary physician and your specialist. You also get a hospice physician who's board certified and specializes in this. So it's back to that team approach. So we work with your team of physicians to make sure we're all meeting what your goals are. You have a choice when you enroll in hospice if you want the hospice physician to become primary and the hospice keeps your other physicians involved and up to date, or if you want your physician to stay primary. It's a conversation you have at the time of hospice admission. A registered nurse is on call 24 hours a day. In addition to being on call, they're making regular visits. You have a social worker and chaplain, just like on the palliative team. In addition to the nurse, social worker, and chaplain, you have a nursing assistant. You have volunteers and grief counselors. I say that the nursing assistants are sometimes the most important person on the team I think, in my opinion, they have the hardest job of any job. How often do you see them? What's really important to understand about hospice, we are pretty phenomenal, but we are not moving into your house. We are not moving in and taking over, and we're not bringing sleeping bags. So our visits are supplemental. The visit frequency is based on how you're doing. We have patients that are doing well, and we may see them once a week. We have other patients that are having a bad time, and we're seeing them every day or a couple times a week. The visit frequency changes depending on how you're doing. But your primary care is provided either by family, loved ones, facility staff, or you hire caregivers to come in if you do ultimately need 24/7 care. Where does the team make visits? It is often misunderstood that hospice is a place. People think that if you enroll in hospice, you have to go somewhere. Most hospice patients live in their own homes in the community. We have hospice patients in assisted livings. We have hospice patients in nursing homes. Some hospitals have partnerships with hospices, and you can have hospice in the hospital under certain circumstances. So that's where I put some hospitals, certain circumstances. But most hospice patients live at home in the community. How do we do this? How do we take care of somebody at home with that team that I just described being available 24 hours a day? But we're not coming in the middle of the night to help with, help to get up to go to the bathroom. We're helping in the middle of the night with symptom management and emergencies. So that's where we really want to make sure you have adequate support at home, and that social worker can step in to help make sure you have that. What else do we provide? Medical equipment. Hospice includes any medical equipment. So that includes wheelchairs, walkers, hospital beds, oxygen, bedside commodes, shower chairs, the list goes on. And we would customize that and cater that based on what your needs are. Supplies, gloves, wipes, depends, that's all provided as part of hospice. And comfort medications. So the hospice benefit includes medications related to your comfort. So comfort to hospice, if you are in pain, anxious, agitated, having uncontrolled nausea, vomiting, diarrhea, constipation, if you're having any of those symptoms, you are not comfortable. So your hospice team will be closely monitoring those symptoms, making recommendations, and prescribing medications as needed. None of our medications or none of our approach is going to speed up the dying process. That's a common misconception. When hospice steps in, we speed up the dying process. Our intent is to provide support. We do not do anything to slow down the dying process. We meet the person where they're at and keep them comfortable. The medications we provide are related to the terminal diagnosis. Any medications this person was on unrelated to their terminal diagnosis or unrelated to comfort will likely still be provided under their regular insurance benefits. And we would discuss that with you and your family if there was any confusions, and making sure that you didn't have any unexpected expenses from medications. How long can we be involved? This is an important question. Hospice is appropriate when somebody has been diagnosed with a terminal illness with a prognosis, which expected prognosis of 6 months or less. Nobody has a crystal ball. We have no idea how long somebody will live, but there are aspects of a serious illness that we look at and a trajectory in an illness that we look at that helps guide us to determine, based on how this person is today, how they've been doing the last few months, how long we estimate that they may or may not live. When you meet with a hospice provider, you will notice that we ask a whole lot of questions. Some of those questions you have probably told a lot of people many times. And we are not doing that to interrogate you. We're doing that because we want to get a picture of what's been going on. So we get to know as much as we can to step in and do what we do. So even though hospice is a 6-month benefit, 2 things I want to mention about that. We have patients that graduate from hospice. We have patients that live far longer than 6 months. We have patients that at the 6-month mark, do we kick them off hospice? Absolutely not. We're establishing how they're doing. We're constantly assessing and seeing what their needs are. And if they do improve and they no longer need us, then yes, then maybe we might transition them to palliative care, or we may graduate them from our programs altogether. It's always a conversation and a choice. And sometimes patients are on hospice for a lot longer than 6 months. Unfortunately, even though the benefit is for 6 months, the average hospice patient is only with us for 10 to 14 days. So all of that support that I described is not benefited from for most patients because the fear of the word hospice, the misconceptions around hospice, the denial, lack of good conversations. There's a numerous list of reasons of why hospice is implemented much later. But I want you all to know that it's a 6-month benefit and you can have it for more than the last few days of life. Who pays for hospice? Medicare and Medicaid pay for everything I described related to hospice at 100%. There is no out-of-pocket cost for anything related to hospice. Most private insurances also have a hospice benefit. Hospice has several levels of care. I'm not going to get into a lot of details about this. I'm just going to mention that there are levels of care. The one that I want to highlight is respite. Respite is a Medicare, Medicaid hospice benefit when somebody is at home and family needs a break, because this is a lot to take care of somebody at end of life, and family needs a break. Medicare will pay, Medicare insurance will pay for hospice to provide respite up to 5 days in either a nursing facility or a hospice inpatient center. So 5 days of full paid care for your loved one to give you a break as the caregiver. Or if you have to go out of town or you have your own emergency. And that 5 days can, of course, be extended in circumstances if warranted and necessary. General inpatient hospice is for people who are in acute crisis. So I kind of refer to it as hospice ICU. So most hospice patients are never in a general inpatient level of care. They're not in an acute crisis, but if they are, you want to know if your hospice provider, what their capability of providing general inpatient level of care looks like. Continuous care support that's provided for symptoms who are in an acute crisis and need round-the-clock care for hospice. Okay, so that's as extensive as I'm going to get about the levels of care. Your hospice team would talk you through those and what was needed if and when you meet with them. Is hospice a place? TRU Hospice is the only one in the Boulder County area that has a hospice inpatient care center. Some hospices have inpatient care centers, most do not. So inpatient care center is a support to patients and families for a short-term length of stay when they're in that general inpatient level of care, so an acute crisis or need respite. Most inpatient hospice care centers are not intended to be a long-term stay. TRU's inpatient care center is conveniently located right here in Longmont. It's on the 4th floor of Longmont United Hospital. If you were interviewing hospice organizations, you'd want to ask if they have any specialized programs that you may benefit from. So there are specific programs for veterans. Veterans' experience at end of life is unique and different than non-veterans. There are specific programs designed for specific terminal illnesses. And then there's end-of-life programs that are additional support for patients in those last few days of life. Grief support. Grief support is a required component of being a participating hospice provider, but it is not reimbursed by Medicare, but it is required. So all hospices provide grief support a little bit different. But so again, if you're interviewing organizations, you want to ask more about that grief support. But grief support is that support that I mentioned that we provide after a loved one has died. We do not disappear from your life. We continue to provide counseling, one-on-one, group counseling. A lot of that's being done virtually now because of COVID, but grief support is available to anybody in the community, regardless if you've had an involvement with TRU. So those of us that have family out of state or out of the country and you experience a loss and you live here in this community and you need grief support, please call us. We're happy to connect you with a grief counselor. I don't want you to think that you only can have grief support by TRU if you have a loved one that was on our service. We have support for everybody as part of being a not-for-profit. We also have specific groups for grief counseling for specific needs. We have a bereaved spouses group. We have a sudden loss group. We have groups for children. So please reach out if you identify at any point that you may need grief support. When do I add hospice to my support team? Diagnosis of a terminal illness. So that's where I was talking about that 6-month piece. If a physician has determined that you have a terminal illness and are potentially in the last 6 months, then hospice would be an appropriate support system if goals are aligned. So we want to identify when hospice meets with patients, we want to make sure our philosophies are in alignment. So has treatment been exhausted and physicians and your healthcare team have maxed their ability to support you with a curative interventions, and now they're recommending you transition to a comfort-focused support? Or is the patient or family identifying that even though there are still treatment options, their goals are no longer treatment focused and they want to be comfortable? So you do not have to wait for a physician to initiate that conversation. A patient can initiate that, or a family, at any time. Treatment can be very burdensome, and sometimes the treatments outweigh the benefit and the side effects. So that is a conversation you want to be having with your healthcare team or a palliative team if you get them involved. You want to make sure our philosophies are in alignment. And again, I mentioned that most of our patients are only with us for less than 2 weeks. You do not have to wait until a physician initiates palliative care or hospice. Anybody can pick up the phone and call your hospice provider and initiate getting us involved. You can call us at any time and ask for an informational visit. Any one of my teammates is willing to come out and meet with you to have this conversation, catering to what's going on with you on a one-on-one basis, okay? These are some resources for you: National Hospice and Palliative Care Organization, and then Medicare Hospice Compare, which is a beautiful site. You can go on there and actually compare up to several different hospices, and they take feedback from families' experiences. So after somebody dies on hospice, families get a survey, and that's a difficult time to receive a survey in a difficult situation. But Medicare takes that feedback, as does the hospice organizations, very, very seriously to make sure we are carrying out our mission and our intention to support those in the community that are needing support during serious illness. So that feedback is then anonymously placed on Medicare's website, and they created this Hospice Compare. So if you were interviewing hospices, that's a good tool. And then more information is all over our website, and you can call us at any time. All right, thank you for your time today. I'm ready, Al, for questions if you are.
Thanks, Jessica. I've been listening to presentations given by Jessica and others on TRU Community Care for several years, and what always amazes me is the statistic you gave that most hospice care is for TRU Community Care is only given over a 2-week period when the benefit is 6 months. And perhaps you can just talk a minute about what the fears are and what the confusion is that prevents people from realizing that they've got this longer benefit and they have the opportunity for the incredible access to care that TRU Community gives.
Great question, Al. I think there's several factors involved in this. I think number one is the misconceptions that the word hospice is associated with, that I hopefully spoke to. The word hospice is feared. Decades ago, it was very much thought of, it's for people who are dying in the last few days, and we have continuously innovated ourselves as hospice providers to add on to that. So it's not for the last few days. There's a lot of fear in our culture of death in general. There's fear of dying in pain. There is denial. There is lack of good conversations and communication between families and loved ones. Our healthcare system is not always trained. They don't typically, our medical providers do not always do rounding or practical experience in with hospice. So they're not always skilled in understanding what we do and what we don't do. And navigating these end of life conversations it takes a high level of skill, and not everybody has the ability to do that. So, and then there's patients and families are in denial, and their goal is to fight until the very last minute, and that's okay. And I think all of those factors contribute to us not being involved in most cases until the last few days or weeks, sometimes the last hours. I've been doing this work for 10 years, and I've had patients on hospice for minutes, literally minutes, and I've had patients on hospice for years and everything in between. And we are happy to do the work no matter how long we're involved for, but we can provide so much more support if we have more time. Because when we're stepping in the last minutes, hours, or days, it's all crisis control and crisis management.
I can just tell you from personal experience, having been involved with this organization for many years, when you hear the testimonials given by people who have had either one or multiple people go through the care process, a hospice care process, it's always overwhelming to listen to the level of support that they get. So everybody that's listening in, I just encourage you to listen to Jessica and get an earlier start. Nobody wants to go through it, but everybody's going to go through it. So having this level of care in our community is truly an amazing benefit. So, definitely think that through and take advantage of it. Jessica, are there co-pays for hospice or palliative care if you're under a medical insurance program? Now, you mentioned obviously Medicare and Medicaid coverage, but would you expect that there would be some if you were on a Kaiser plan or Anthem or one of the other plans out there prior to being old enough to qualify for some of those other national plans?
So, it depends on the individual's insurance plan. A lot of times, we all are familiar with that word deductible. A lot of times with serious illness, people have had multiple hospitalizations and have been going through treatment for long enough. By the time that they are talking to hospice, their deductible has been met. So, which means that hospice is covered 100%. But we certainly, if there was any concern about out-of-pocket cost, we have a billing team, a billing group of gurus that we pull in immediately and run those insurance. So people are told right out of the gate if there is any out-of-pocket expense, and that's palliative care or hospice. And TRU is a not-for-profit. So I can say from experience that we have never turned anybody away for palliative care or hospice for an inability to pay. We have taken care of homeless people. We have taken care of people with no insurance, no means of paying for us, and they have received the same level of care as anybody else. Palliative care, we bill as specialists. So if they did not have Medicare or Medicaid, they would look at their insurance card and usually right next to or on the side, it says specialist. Sometimes there's a percentage or an amount. So that would be what we would bill. And sometimes even that small copay is too much of a burden. And again, that would be conversations we would have and not refuse to provide care.
Thank you. Great answer. What is the process if somebody is in a position to need palliative care? What is the process just to get in contact and talk to TRU?
So it could be as simple as you calling the main number and asking to speak to the palliative team, and you will be connected, and you could set up an informational visit and somebody can come over or just talk over the phone. You know, we're sensitive to COVID, people not wanting us to come in or start taking extra precautions. And or they could initiate it with their physician in the community. You know, depending on their physician, sometimes they're, you know, absolutely on board with palliative care or hospice, and sometimes they're lacking some knowledge about it. So if you speak to a healthcare party in the community and they are not on board with you calling a palliative team or hospice team, and you are, don't listen, just pick up the phone and call us. And if we need to get their involvement, we certainly will initiate that on your behalf.
That's great. Thank you. You know, Jessica, we don't have any additional questions from the audience, and your presentation is so thorough because you ask the questions during your presentation because you're so experienced at it. You know, I love listening to you because of the level of knowledge that you have about this. So I thank you so much for joining us today and sharing your incredible knowledge and just giving us a better understanding of how palliative care and hospice care work through the TRU Community Care Network. So thank you so much for doing this today. And I thank everyone for joining us today and look forward to seeing you on another call.
Okay, thank you, Al.
Thank you. Good luck.
Thanks.